was just following Diego.
All right.
Because I'm working with Christmas. So you'll work.
I'm just going to get started then. So we're just going to talk briefly about some basic applications of abdominal ultrasonography in the critical care setting. I'm Ajaz. I've met a lot of you, but not all of you. I started in November, and I'll be covering the MICU about 6 nights a month and covering daytime MICU service as well. Pretty much a week a month or so. So as far as like abdominal ultrasound exam considerations, some of the things that are nice about ultrasonography and are applicable to abdominal examination as well using that modality is that it's a portable, readily repeatable exam. So you kind of avoid taking the patient out of the ICU. It can be done at the bedside. It can be repeated at the bedside without having to transport the patient. You could image a lot of organs in the abdomen using a single curvilinear probe, or if you don't have a curvilinear probe, then the phased array cardiac probe that they use for echo is similarly useful for abdominal imaging and is commonly used in many settings for abdominal ultrasonography. But the caveats that apply to abdominal ultrasonography are similar to caveats that you might imagine apply to pleural ultrasound or echo, that skill acquisition takes time, and the sensitivity and specificity you actually obtain with your examination tends to be operator dependent. Anytime you read any paper that pertains to the use of ultrasound in like a bedside clinical setting, you want to ask who was doing the ultrasounds and how many have they done, because the sensitivity and specificity findings that they'll report will be widely variant depending on like who was doing the exams and how much training they'd had. Other things that are often significant confounders to the use of abdominal ultrasonography at the bedside is that patient habitus can make image acquisition particularly difficult and sometimes render the exam almost a waste of time if the habitus or bowel gas or other confounders are degrading the image quality to such an extent. So having said that, what are things that you can use abdominal ultrasonography for in a clinical context that are relatively straightforward and kind of basic things to do? And the way I kind of approach it is I think of it as, are there some polar questions, meaning they have a yes or no answer that you can ask a polar question with a yes or no answer, perform a focused abdominal ultrasonography assessment, and gather a item of data that helps you answer that question. So if you're evaluating a patient who's hypotensive in the appropriate clinical context, your abdominal ultrasound can help you answer if there's intraperitoneal blood or not. If there's decreased urine output, you can use focused abdominal ultrasonography to assess. Is there urine in the bladder? Is there hydronephrosis of the kidneys suggestive of obstructive uropathy? If you're performing paracentesis, you can use abdominal ultrasound to help you answer the question, is there a safely accessible, adequately sized pocket of ascites that you can actually aspirate? And if you're assessing volume responsiveness, and this is something we'll touch on again when I think we talk about echocardiography, but when you're assessing volume responsiveness in a patient who's being resuscitated from shock, you can use IVC ultrasound to ask, is there a respirophasic variation of the IVC? So one of the most commonly taught applications of abdominal ultrasound in critical care and emergency medicine is the FAST exam, which is the focused assessment with sonography for trauma. And in a medical critical care setting, I would say that the reason to talk about this examination is more so because it provides a basic framework for actually how do you obtain some rudimentary abdominal images. It provides a framework for image acquisition and thinking about how do you image the liver, how do you image the kidneys, how do you image the pericolic gutters, the bladder, and so on. The important caveat is that in the medical ICU setting, whereas in a setting of a traumatically injured patient who's hypotensive, the likelihood that the free intraperitoneal fluid you see is blood. In a medical ICU setting, it could be ascites, it could be peritoneal dialysate, it could be a variety of non-bloody fluids. So that kind of limits its application in contrast to what the FAST exam was originally intended for. But we'll talk about it because, as I said, it provides a framework for how do you obtain some basic abdominal images. So the classic FAST exam consisted of four imaging sites. So one is a subxiphoid cardiac view, and the subxiphoid cardiac view is analogous to the standard subxiphoid cardiac views that are obtained during cardiac echocardiography. Um, as you see here, the probe is positioned in the subxiphoid space with transverse orientation to the body. And what you obtain when you do your image acquisition is you'll have a liver at the top, which is providing an acoustic window to get images of the right ventricle, right atrium, left atrium, and left ventricle. And depending on, and this is something that Shruti kind of alluded to, depending on where your indicator is, it'll basically affect which way the apex of the heart is pointed. So if you think about a FAST exam being done with the indicator to the left and the probe positioned with the indicator to the right of the patient or to your left, then the apex of the heart is going to be pointed to you. Yeah. And if you were doing it in the context of a cardiac echocardiography, that the apex would be pointed the opposite way. But the superior to inferior orientation of structures on the screen, with the right ventricle and right atrium at the top, will be the same, and left ventricle, left atrium below will be the same. So just kind of touching on this briefly, because our focus is on abdominal imaging, you can use this in the context of a hypotensive patient to ask, is there a large pericardial effusion? Is the right ventricle significantly dilated relative to the left ventricle, or is the ventricular function grossly hypodynamic? But kind of moving to the images that are more germane to our topic at hand, in the second kind of classical imaging acquisition site in the FAST exam is the hepatorenal recess. So typically this is the Morrison's pouch view that people often talk about. So you'll have the probe in a long axis orientation with in the intercostal space at the 10th, 11th intercostal space at the posterior axillary line. And if you have positioned it accordingly, what you're looking for is an image like this with the liver and the classic liver echo texture, a bright diaphragmatic line, and then kidney outlined here with the fascial planes of the kidney closely abutting the liver. And this is a normal hepatorenal view. And because the fascial interface of the kidney should be abutting the liver in most normal studies, any anechoic or black material that you see in that space was considered to represent fluid and is potentially pathological. And again, in the classic context in which the FAST exam was performed, which was an acute traumatically injured patient, the default interpretation would be that anechoic fluid present in the recess between the liver and kidney is blood. One kind of a good thing as a pearl to know about this particular view is that fluid often collects near the inferior pole of the kidney. So it's important when you're actually performing these imaging studies to actually fan through the kidney and the liver. So by fanning through is you'll put the probe in the site we talked about, obtain your view of the liver and the kidneys, and then rotate the probe up and down in order to make sure that you image the complete interface between the liver and the kidney and see the inferior pole of the kidney, because as we mentioned, fluid will start to accumulate there first. Moving to the other side of the body, you'll try to image the splenorenal space. And the splenorenal space is a little bit more cephalad and a little bit more posterior compared to the hepatorenal space. So typically you're looking at a posterior axillary line position somewhere in the 6th to 9th intercostal space. One other thing that you'll note in this image is that the probe is rotated slightly, and this is often commonly employed in order to get between the ribs and avoid imaging artifact from rib shadowing, obscuring the structures you actually want to see. So if you in the context of a normal study, what you'll see is a spleen with an echo texture similar to the liver. You may see a bright diaphragmatic line here. This patient has a small amount of pleural fluid, which is the anechoic material you see here, and then kidney again with bright fascial interface, and then renal calyces here. Unlike the hepatorenal view, where fluid will tend to accumulate between the liver and the kidney, in the splenorenal space, the fluid, when it accumulates, tends to accumulate above and inferior to the spleen, so not necessarily kind of eroding the interface between the spleen and the kidney. So you basically look for fluid above and below the spleen, primarily between the spleen and the diaphragm, or inferior to the spleen on your image. And again, just as it is true for the hepatorenal view, you kind of want to fan the probe through in order to kind of view the spleen in more than one position to make sure you're not missing a smaller amount of accumulating fluid. And the last of the four classic FAST exam views that people talk about is the suprapubic view, in which you're looking for fluid posterior to the bladder in the pouch of Douglas. And it's kind of, some people classically used to say that, oh, the Morrison's pouch is the first place that fluid will accumulate in the supine patient because Morrison's pouch is the most dependent position in the patient. And technically speaking, that's true for the superior part of the abdomen. So for the superior part of the abdomen, Morrison's pouch is indeed the most dependent position, but anatomically, the most dependent position in the abdomen is actually going to be posterior to the bladder. The problem is that image acquisition in the suprapubic space, like we'll talk about, is a little bit more technically challenging than looking in Morrison's space. And for that reason, you might see fluid accumulations more easily in Morrison's pouch versus the retropubic space. But small amounts of fluid, especially in an upright patient, you're going to see first in posterior to the bladder. So this is the standard transverse view that people initially used to talk about obtaining when they would perform the suprapubic view as part of the FAST exam. So you see a bladder filled with essentially anechoic fluid, which is urine. You see a bright fascial interface essentially between the bladder and the abdominal structures outside of it. This is a longitudinal view of the bladder, which I think more and more people are often advocating as the first view of the suprapubic space that you should obtain when you're doing FAST. And the reason for that is that in the long plane, you can actually better delineate the relationship of the bladder to adjacent peritoneal structures. And it helps you discern, in many cases, the retrovesicular space more clearly. And this is a pathological study in which the bladder is filled with anechoic urine. Here's the fascial interface of the bladder, but posterior to that, we again have anechoic fluid, which should not be there. And this is, again, in the appropriate clinical context, a traumatically injured patient, potentially hypotensive, would be deemed to be blood, most likely. In the female, so these images, which I showed you previously, were from male patients. In a female patient who still has a uterus, what you'll actually see is going to be a structure which is not entirely anechoic posterior to the bladder, and that's the uterus, which is important to kind of keep in mind. And the uterus should not have anechoic collections posterior to it or around it. And if you have a traumatically injured female patient and you're performing a longitudinal view of the suprapubic space, and you identify again hypoechoic structure posterior to the bladder, that's the uterus, but anything anechoic around that uterus is going to be, again, deemed to be blood in the appropriate clinical context. And as I alluded to earlier, even though the retrovesicular space is probably going to be the first place that small amounts of fluid will accumulate, it can be a technically challenging view to obtain, because if you have a bladder which has urine within it, the urine provides a good acoustic window for imaging the retrovesicular space, because sound travels better through liquids than it does through air or decompressed tissue, essentially. But if you have the bladder as an acoustic window and there's urine within, it's going to be probably more sensitive than looking at Morrison's pouch. Just going to touch briefly upon this EFAST. So if you spend time on a trauma service or in trauma ICU, you might hear them say, "Oh, EFAST," or "We performed an EFAST exam." And all that the EFAST means is that it's an extended FAST exam. And the extended portion of the FAST exam is that in addition to obtaining a subxiphoid, hepatorenal, splenorenal, and suprapubic view, they'll perform ultrasonography in the midclavicular line of the anterior chest from the clavicle down the anterior ribs in order to assess for a pneumothorax by looking for lung sliding and seashore versus stratosphere signs. And they'll also, when they're performing the hepatorenal and splenorenal views, they will also pay attention to slide the probe upward in both of those areas in order to image above the diaphragm in order to assess for fluid in the pleural space, which again in this clinical context would typically be interpreted as being blood and hemothorax. So this is an example of a right hepatorenal or right thoracoabdominal view in which we have lung tissue visible with anechoic black material surrounding the lung tissue, and in this clinical context, it would basically be blood that we would consider it to be. This bright line is the diaphragm being partially imaged, and then again we have the typical echo texture of the liver. So FAST exams, the pros of the FAST exam are that it's portable. The patient doesn't need to go to CT. It can be done at the bedside in an unstable patient. It can be repeated. And in the hands of very experienced practitioners, it's extremely sensitive. So you can detect as little as 50 to 100 mLs of blood or free fluid in the peritoneal space, people say. If you look at the bulk of literature regarding FAST, and there's multiple papers that have been published on this since FAST has been popularized in American medical practice since the 1990s. Probably in the hands of typical operators, you need about 200 to 250 mLs of peritoneal fluid to be identified by kind of a typical practitioner. And then, as we kind of talked about in Shruti's discussion of pleural and thoracic ultrasound, the ultrasound of the pleural space performed as part of an extended FAST exam could potentially identify as little as 50 to 100 mLs of free fluid in the pleural space in the hands of an experienced operator. And this is in contrast to chest radiography, where you might need even as much as 200 mLs of fluid to identify. You might need as much as 200 mLs of pleural fluid to identify an abnormality on an upright chest X-ray. Versus chest X-ray, thoracic ultrasound performed in the context of extended FAST exam has been demonstrated to be more sensitive for a pneumothorax, more rapidly performed, lessening time to chest tube placement, and so on in published literature. The cons of the FAST exam, especially relevant to performing it outside of a trauma type of setting, is that it doesn't tell you if it's fresh blood or ascitic fluid or peritoneal dialysate, or perhaps even just physiologic fluid in the retrovesicular space in a woman who has perhaps a ruptured ovarian cyst or something of that nature. You need to be careful when performing the exam in order to miss clotted blood. Clotted blood will not have an entirely anechoic echo appearance. It may have a complex echo texture, and novice operators are known to miss clotted blood and consider that this is just part of the liver or normal liver echo texture. It does not allow you to assess for retroperitoneal injuries or retroperitoneal structures. It's notorious for missing hollow viscous injuries because of the amount of bleeding that associated with hollow viscous injuries may not be that high. And then even in the case of large, or I shouldn't say large, but even in the case of moderate or small intraparenchymal hematomas in the liver or spleen, in the hands of non-experienced operators, those injuries may be missed because they may not discriminate the complex echotexture of a liver hematoma from normal liver parenchyma or spleen parenchyma. So if you look at published sensitivity for the FAST exam, you'll see a huge range in the literature available. Anything from like 40 or 50% to like 90%. And the reason for that sensitivity is, again, what I talked about earlier. Anytime you read any paper about clinical bedside ultrasound, ask who was doing the studies and how many of those studies have they done. So basic considerations of abdominal ultrasound in the context of clinical questions such as, why does my patient have decreased urine output? This is something that you may find yourself commonly performing in the ICU. So one of the quickest questions you can ask is, is my Foley catheter in the right place and is the bladder decompressed? If you have a Foley catheter in place and you perform a suprapubic view of the bladder, suprapubic view of the bladder as per the FAST exam suprapubic view that we talked about. This is a transverse. This is actually a longitudinal view of the bladder, which has been largely decompressed, and this structure that you see here is actually the balloon of your Foley catheter, which you should be able to identify. So if you have Foley catheter balloon within the bladder and the bladder is distended like this, that tells you that your Foley catheter is probably not working, and that may be a reason why your patient has decreased urine output. Is there retained urine in the bladder and the patient has urine but they're just not voiding because of obstructive uropathy distal to the bladder? You can actually measure the urine volume within the bladder using kind of an ellipsoid formula. So you image the bladder in a transverse plane and then image the bladder again in a longitudinal plane, and basically your width times your length times your depth of the bladder times of about 0.5 or so gives you a rough estimate amount of volume in the bladder. So if there's several hundred cc's of urine in the bladder and nothing has come out, patient probably has some form of obstruction in the distal bladder. Put a Foley in, and that will answer perhaps why your patient has decreased urine output. Looking more proximally at the urinary tree, we often can assess for hydronephrosis very quickly at the bedside. And you would assess for hydronephrosis by using an imaging approach pretty similar to the FAST exam approach, which is used to assess the hepatorenal and splenorenal spaces, essentially. And when you image the normal kidney, you'll essentially see, as we talked about in the FAST exam, the typical echotexture of the liver, a very, very clean, bright line between the liver and the kidney, which is the hepatorenal space without any anechoic fluid in it. You'll see fascial delineation of the kidney as a bright line here, and then normal renal cortex has this type of echotexture, and then the renal pelvis and renal calyces have bright hyperechoic echotexture. So when you have mild hydronephrosis, that bright hyperechoic pelvic and renal calyces echotexture is kind of replaced by anechoic urine fluid, which is essentially should not be there. So this would be categorized as mild hydronephrosis. Looking at more moderate hydronephrosis, you'd see something like this, where the calyces are starting to be kind of ablated, and all you can kind of see is even the edges of the calyces within the normal renal echotexture. And then severe hydronephrosis, you even have cortical thinning. So the normal renal cortex texture, which is here, is now pretty much gone. It's been compressed. It's been compressed to this thin rim you see here, and you have almost entirely central space filled with anechoic urine. And this is perhaps the remnant. This is perhaps an imaging cut through renal calyces with a hyperechoic echotexture that we would expect. So at the bedside in the ICU, I'm not a radiologist, so I usually, if I see mild hydronephrosis, I'll say maybe it's mild hydronephrosis, but I don't know. If it's moderate or severe, I can usually pick that up, and that usually tells me the patient most likely has obstructive uropathy that needs to be addressed. So in the setting of a patient who is perhaps having septic shock secondary to urinary source, if you haven't already imaged them with a CT, or if they're too unstable to go to a CT, you should be doing this. And obviously if they have obstructive uropathy, decompressing that side of the urinary tree. One other big caveat with this is that although this is a relatively easy skill to acquire at a beginner level, the big pitfall with this one is it may be tough to call mild hydronephrosis, but moderate or severe are relatively easy to pick up. And the caveat to keep in mind is that renal cysts can have a kind of confusing echo texture that can look like this. And the way to avoid being tripped up by renal cysts is image the whole kidney, so superior to inferior pole, and fan all the way through. And with the renal cysts, as long as they're not parapelvic, meaning that they're very close to the renal pelvis in terms of location, you'll find that the renal cyst is probably mostly cortical based and mostly peripheral, at least in some of the cuts you'll obtain, and that may help you identify a renal cyst. Also, if you find that patient has what appears to be severe hydronephrosis, or what looks like to be severe hydronephrosis, that can also be sometimes confounded by patients with polycystic kidney disease, because what you'll see is black all through what should be a kidney, and what that typically is it's a polycystic kidney. The way you can give yourself a clue, and as a good practice to have in general when imaging the renal tree or any symmetric structure, is image the other side. So polycystic kidney disease, the other kidney will look the same. You'll be like, this is probably not severe bilateral hydronephrosis unless they have obstruction at the bladder or below, essentially. Or it'll be asymmetric in appearance, which will confirm again your clinical suspicion that they have unilateral hydronephrosis on that side. So bedside ultrasound for paracentesis. So the focused question you're asking yourself when you do this as part of a basic skill in critical care abdominal ultrasonography is there a safely accessible, adequately sized pocket of ascites? And typically speaking, with a blind technique, you would perhaps say, I'm just going to go to the left lower quadrant or some other traditionally deemed safe site and try to do a tap. But the reality of paracentesis or thoracentesis is that the optimal site is going to be where the depth of your target fluid is greatest, and the distance to that target fluid is the smallest, and there's the least number of structures in the way to potentially cause iatrogenesis with. So in this context of paracentesis, you want to avoid cutaneous collateral veins, you want to avoid the inferior epigastric artery, you want to avoid cecal perforation or small bowel perforation or bladder perforation, which can all occur in the context of a blind paracentesis, especially when there isn't much ascitic fluid. And of course, ultrasound pre-scanning your intended site on the abdomen may help you avoid hernias or surgical scarring and adhesions. So things that can make paracentesis challenging are loculated collections of ascitic fluid, as well as narrow or small pockets of ascitic fluid. And pre-scanning can help identify these potential complicating factors and reduce the number of dry taps and reduce the number of complications. And there's an emerging number of studies which demonstrate consistently higher success rates with image-guided paracentesis versus traditional blind techniques, and potentially even lower complication rates in terms of hematoma, seroma formation, and perhaps perforation of bowel. So there's a variety of techniques that have been described, or actually there's not a variety, there's basically two techniques that are most commonly described for how to perform image-guided paracentesis. There's the pre-scan and mark technique. So you pre-scan, you identify a pocket of fluid of sufficient depth and with no interfering structures in between your intended path of needle target, and you mark the site on the external abdomen, put the ultrasound probe down, and then put your needle into the site you've marked. I think that's kind of an inferior technique to using the real-time image-guided technique. And the advantage of the real-time image-guided technique is that if you are able to manipulate the probe up and down and fan as you advance the needle, you can actually visualize the tip of the needle entering into your intended pocket of ascitic fluid. And you can avoid, again, potentially perforating bowel, which may be close by. And similar to vascular ultrasound, it can be sometimes tricky to identify the needle tip, but the needle tip is going to be a bright hyperechoic thing surrounded by anechoic usually or hypoechoic ascitic fluid, which kind of makes it a little bit easier to pick that up. So, and then kind of finishing out briefly with talking about abdominal ultrasound in assessing volume responsiveness. So, in the context of resuscitating patients who are hypotensive, I mean, we often ask ourselves, is giving them additional IV fluids going to raise their cardiac output? That's the question we want to know. Is that my volume challenge going to increase their cardiac output and address their shock state? And we know that right atrial pressure and CVP data as static numbers are pretty lousy predictors of this. But and as part of a standard echocardiographic examination, most of the time the echocardiographer will include some kind of estimate of the right atrial pressure based off of the IVC assessments that they do. And this table is a pretty common example of what echocardiographers are using to estimate right atrial pressure when they do echoes. So they basically look at what's the IVC diameter, and if it's less than 1.7 or 2 centimeters or greater than 1.7 to 2 centimeters, and is there 50% or more collapse of the IVC with respiration? And based off of that, they can estimate right atrial pressures as you see noted in the table. But again, we beyond kind of wanting to estimate right atrial pressures, our clinical question in the context of bedside abdominal ultrasound in critical care is, does actually ultrasound in the IVC help you answer the question of, will giving more fluid to the patient raise their cardiac output? And there's a variety of studies that have been published attempting to address that question. So two of the most commonly cited studies were actually performed in mechanically ventilated patients. So this one by Barbier from Intensive Care Medicine that was published in 2004 was a prospective observational study. It was 23 mechanically ventilated patients who were getting volume control mechanical ventilation with tidal volumes of about 9 mLs per kg. And these are all patients with severe sepsis and septic shock. And what they were looking at as their assessment of respiratophasic variation of the IVC is this distensibility index, this DIVC. And they calculated as the maximum diameter of the IVC minus the minimum diameter of the IVC divided by the minimum diameter of the IVC times 100. And they measured the distensibility of the IVC. Then they gave their fluid challenge, which is about 7 mLs per kg as a bolus, and they were looking for a cardiac index increase of about 15% in order to define a volume responder versus a volume non-responder. So they gave their 7 ml per kg bolus of, I think they used synthetic starch over 30 minutes, and they measured cardiac index by echo pre and post volume challenge, and they were looking for 15%. And what they found was that this distensibility index of the IVC, using a cutoff of about 18% a distensibility index, was discriminatory with 90% sensitivity, 90% specificity for volume responders who increased their cardiac index by 15% after that bolus. And consistent with multiple other published papers, they found that the baseline CVP, a static CVP or static right atrial pressure measurement, prior to their volume challenge was not predictive of volume responders. In that same issue of intensive care medicine from September 2004, Fessel and Tabul published a similar study of IVC diameter to assess fluid responsiveness. So again, it was vented patients, 39 vented patients. They were getting 8 to 10 mLs per kg of tidal volume in a volume control mode. They were all patients with septic shock. These guys were using cardiac output as opposed to cardiac index, again measured by echo, as their assessment as their assessment of cardiac function improvement after 8 ml per kg bolus of, again, a synthetic starch, and they were looking for a 15% bump up in cardiac output. And the number that they used is a little bit different in terms of how it was derived. So these guys used this, what they call distensibility of IVC, so max minus minimum diameter divided by minimum diameter times 100. These guys used delta IVC, which they calculated as maximum diameter minus minimum diameter divided by the mean diameter. So they basically took the max and the minimum, they averaged them, and then the difference between the maximum and the minimum was then normalized by the mean and then multiplied times 100. So slightly different number, but similar concept. And they found that the delta IVC cutoff of 12% allowed identification of responders with fairly good positive and negative predictive values. So it works well, perhaps in mechanically ventilated patients who are relatively passive, receiving 8 mLs per kg of more of tidal volume. How does it work in people who are spontaneously breathing, where the tidal volumes that are being inspired may vary more from breath to breath? So this is a study that was published pretty recently in Critical Care in 2012. And similar to the other studies, a prospective observational study. This is 40 spontaneously breathing patients with circulatory failure. And 60% of the patients had sepsis as a cause of their circulatory failure, unlike the two previous studies where all the patients enrolled were septic. And again, everybody's using a slightly different assessment of cardiac function improvement. These guys were measuring velocity time integrals. So velocity time integrals is kind of an echocardiographic parameter that's correlated with your stroke volume, essentially, is what they're measuring. So they're just measuring the stroke volume component of your cardiac output, whereas the other two papers included heart rate in some form as part of their assessment of cardiac output change. So they gave a 500 ml, again, synthetic colloid bolus, looking for an increase in their velocity time integral of 15%. And once again, there's a different assessment of IVC respiratory phasic variation being calculated. So these guys use what they call the collapsibility of IVC index. So this is the maximum minus minimum diameter divided by the maximum diameter times 100.
So is there a reason why they are using this different? Is it just to improve the results?
So these guys may have been doing that. These two guys may have been doing that. These guys calculated it two or three different ways. So these guys calculated all ways, and they said this one works the best. And they said so these people did not disclose if they calculated it any other way and then picked their distensibility index, delta IVC index. These folks calculated it multiple different ways and said this collapsibility formula works the best.
I bet that second one includes Michard. The pulse pressure variation, which is how they calculate pulse pressure variation as the difference over the mean. So I don't know if that's why they chose to do it that way.
Yeah, with the mean at the bottom, yeah.
I also wonder if they're trying to sort of have it be their marker, which takes hold. And
that's a good point. Yeah, it may be. That may be. You're right. That may be why.
Yeah.
So what these guys did is that they calculated it using different formulas, and they worked out ROC curves for the different formulas, and they found that the area under the curve of the ROC analysis for this collapsibility IVC index was kind of moderate, 0.8, 0.77 in that neighborhood, and the best cutoff for the collapsibility IVC index itself, so the best CIVC value itself was 40%. And that had a sensitivity about 70%, specificity about 80%. So if you have a collapsibility IVC value greater than 40%, that's probably associated with fluid responsiveness in a spontaneously breathing patient, but a value less than 40% is not going to exclude fluid responsiveness necessarily. So one other thing that's important to know about all three of these papers. All three of these papers excluded patients with right ventricular failure. And that's an important caveat to know, is that patients who have significant RV dysfunction or frank right ventricular failure, this kind of goes out the window. So,
and I saw there was a paper actually specifically looking at patients who have RV failure and trying to apply these concepts, and they actually don't work.
Yeah.
Yeah.
And
Beyond
then
just like not
yeah.
having been studied in these settings.
And it physiologically makes sense. Yeah.
Valvular disease, I imagine. Valvular disease and diastolic dysfunction.
Yeah. So if you have severe TR, it's not that's going to over. Yeah, it's probably
But
not
even
gonna work.
diastolic dysfunction.
So I don't think they excluded people with diastolic dysfunction. So in fact, I'm pretty sure that they didn't exclude people with diastolic dysfunction in this paper because they actually calculated, they actually did diastolic interrogation of the patients and actually used, they actually had E to E prime like as one of the parameters that they're looking at as well in this paper, and still this collapsibility formula had some value. So in terms of like how do you technically perform this study, there's actually a very good video available. In terms of basic abdominal ultrasonography applications in critical care, as you start out, it helps to ask really focused questions with polar answers, yes or no, and then gather data using some of the basic imaging techniques we employed, and you can build off of the fast imaging techniques to help you gain images of the